welcome to Headspace, the 6-part radio series looking at mental health in Ireland. This series was produced and presented by Heather MacLeod and Gerard Coonahan and made with the support of the Broadcasting Authority of Ireland. In this series, we not only explore in an accessible manner 5 specific areas of mental health, including depression, suicide, schizophrenia, eating disorders and obsessive-compulsive disorder, but we then round off the series with a 6th final show on psychologists and alternative therapists. It's one thing to deal professionally with a person suffering from a condition such as anorexia, but what have they learned from their daily struggle with mental disorder? And what is the best practice when dealing with people suffering from mental disorders? We talk to the psychiatrists, the professors, the psychologists, the therapists, the help organisations, and most importantly the patients and survivors, with the aim of providing a fascinating but simple insight into the world of mental disorder. This second show in the series examines obsessive-compulsive disorder, or the abbreviation normally referred to of OCD. Around 3% of the population suffers from obsessive-compulsive disorder. It is listed as one of the top 10 debilitating conditions. What leads the OCD person to feeling compelled to voluntarily perform irrational, time-consuming and distressing physical behaviours? Treatments include medication, talk therapy and cognitive behavioural therapy, referred to as CBT, which we discuss with Debbie van Tonder, OCD course facilitator, nurse and therapist on the anxiety disorder team at St Patrick's Hospital, OCD specialist and advisor to OCD Ireland Leslie Shoemaker, and OCD sufferer Gillian. Jerry began by asking for a simple explanation of the condition OCD.
OCD is broken down into 2 parts. We have the obsessions, and an obsession can be a thought, it can be an image, or feeling like you're going to do something like scream in a crowd. And then what happens is that thought that comes into your mind, the image or the picture, it's telling you to do something, and it's making you very upset and very anxious and very distressed because you have to do an action to make this go away, and that's what we call the compulsion. Now the compulsion comes in 2 forms. We have like David Beckham. He's a great example. He's into symmetry. So when he goes into a hotel room, he's got to fix all the pictures on the walls, the pillows on the bed, everything so that it's perfectly symmetrical. I remember once seeing his fridge on a TV show. All the Pepsi cans were lined up in an amazing symmetry, and his wife said he'd throw away the extra ones. But there's another type that we don't talk about as much, and this is the type where it's mental rituals, meaning they're in the head, and they're really hard to see. And it could be counting, it could be praying, it can be even thinking the same thought over and over and over again. But the problem is this becomes like we would call it a vicious cycle, a very psychological term. And it's a fancy way of just saying it's a pattern that keeps happening over and over and over again, like a hamster wheel, and it just never stops. Even though that obsession, your OCD, is essentially saying, if you do it one more time, I promise I'll go away, but it never does.
Okay, and maybe I can add to that, Leslie, is the fact that obsessions are intrusive, so we're not in control of them. They can just jump into our heads, and that is what makes it part of the disorder, and that is what makes it so uncomfortable, because they jump into our heads. It is against our norms and values, so it often goes against who we are, and that is what caused the upset that you were talking about. And the compulsions that Leslie was talking about, and the behavior, the things that we do, like washing hands or checking, is to actually get rid of the thought. It's actually to get rid of this upsetting thought. So it has two actions. So it gets rid of the thought and it gets rid of the anxiety. So it works in 2 ways. So we call it neutralizing behavior and we call it safety behaviors. So it's really, the way Leslie was explaining it, a very nice explanation of quite a complex disorder.
But I could say 100% of the population have intrusive thoughts.
Oh, yeah. I could maybe say to that, I mean, obsessional thoughts are normal. I go to the airport and I have to have my passport with me when I travel. Whenever I want to leave Ireland, I have to make sure I have my passport. So I check my passport about 50 million times before I get to the airport. And that's quite normal, obsessional behavior. It's a normal thing to do. So, but it is when it becomes disabling, when it impairs your functioning, that we would then say that it becomes a disorder. So obsessional thoughts would be very, very normal. And also ritualistic behavior is very normal. So if you have your cereal for breakfast, we have it in a specific way. If you think about the way you have breakfast, we all have Leslie had a bagel for breakfast, so she had the same bagel from the same place and the same coffee for breakfast every day. That is a ritual. All of us have rituals that we do every day, and we don't even know it. So we all have a touch of OCD.
But there's something about with OCD that, unfortunately for people with OCD, when the thought comes, it doesn't go away. It gets stuck in this hamster wheel. Whereas for myself, I can think a lot of the same types of thoughts. Oh, I've just handled money. My hands feel dirty. I need to go wash my hands. And I can go and do that, and I'm satisfied. I don't worry about it again. But unfortunately for somebody with OCD, the thought keeps coming back over and over again. Then they have to go do the action over and over again. The thought just gets stuck, and it keeps replaying over and over and over again.
And could somebody say, oh, yes, well, I'm an expert, that's probably genetic?
Possibly. I mean, they reckon, current research would say in approximately 12% of the cases. My suspicion it's probably higher, but we don't have the technology to really thoroughly investigate that yet. But I'd say in the next 15, 20 years, we're going to have a lot more answers.
Is there even any age that it starts off, and then we can deal with the triggers as well?
Well, I could maybe speak from my experience. I work at St. Patrick's Hospital, and certainly quite a few people with OCD would have started OCD, having OCD thoughts or behavior when they were very young. With specific triggers, maybe it was about harm and responsibility, about having to make sure that they were safe or their family members were safe. So there was an increased sense of responsibility there. But also there are the other people or other people that would say that the OCD started much later. Or often I would think that OCD started much younger, but it's often diagnosed much later, and it's only diagnosed when it becomes problematic. Certainly the incidence of boys when they were younger would be higher, but it would balance out later on. So there's a whole lot of statistics around it, but it's really not clear, and it's difficult to say, well, it started at that age, or that are the triggers, or those things are the triggers. The triggers are different for all people. Every single person would be vulnerable to specific triggers. So I might be vulnerable for causing harm. Leslie might be vulnerable for contamination. So it will differ across the spectrum. You can't really say.
I mean, there's some really interesting discussions happening about obsessions. Like, we know that OCD happens in very specific categories. You know, we were talking about, contamination. That would be hand washing. We have orderliness. We have symmetry. And we have a few others. And I was at a talk a couple of years ago with a psychiatrist named David Veal, fabulous guy, very well, respected in the field. And he threw out this really interesting idea that the obsessions, there were two ideas he threw out. One was, in some cases, the obsessions take the form of what's happening in society. Now, I have a lot of clients at the moment, and this is going to sound really weird, who are afraid of being a pedophile. 10 years ago, I had a lot of clients who were afraid of being gay. Somewhere in between, I had a lot of clients who were afraid of having HIV. And in these cases, it really is a reflection of what was happening in Ireland, in Dublin, and even in the world. And then there's another theory around the obsessions, and I have other clients in my private practice that fall in this category, where the obsession takes the opposite of what they value. So if I would get in a mother, for example, who would say that she was afraid of harming her children, that she'd be terrified of harming her children, I would know that she's a fantastic mother, because this is what she values. This is why the OCD is taking this form. The obsession has to be something, I love this phrase, I read it in a book years ago, personally repugnant. It has to be something that sets off your alarm bells and really, really makes you go crazy. It has to upset you. So of course it's going to take the form of something that you love, that you care about, that you value. And so it's interesting to see what people's are obsessions about, but what is most critical in saying this is, number one, the obsessions are not psychologically meaningful. There's no meaning attached to it. It's not like dream therapy. Love doing dream therapy. We find psychological meanings in the symbolism, in the story. The content of my clients' obsessions, it's not meaningless to me, but I don't really worry about it. And if somebody has a fear of doing harm, whether it be physical harm, or if they're afraid they're going to harm somebody in a sexual way, they're not going to. Because believe it or not, the anxiety, the very thing that they're trying to make go away, is the very thing that stops them from acting on it.